Assalamu alaikum. My name is Bismaa Anwar. I'm a licensed mental health counselor. I'm based in New York City, and I work a lot with the Muslim community over there and do a lot of workshops and provide resources. I also work at Mount Sinai Hospital in psychiatry, and I have a private practice where I primarily work with Muslim families. So I'm here to talk to all of you about my work with the Muslim community, particularly with the youth, with preteens and teenagers. And so I'm talking about investing in the future of our ummah, which is suicide prevention amongst Muslim adolescents, which has been on a rise. And I'm going to be talking about one of my cases that I dealt with and how, I was able to sort of work with this adolescent, and also kind of what are some of the strategies and things that I, thought that we needed more of in the Muslim community, as well as equipping their families with resources and ways to deal with this. So some of the goals for this presentation is to help mental health providers conceptualize treatment of Muslim adolescents who are, experiencing suicidal ideation, to be able to identify certain elements and factors that may worsen suicidality in adolescents, which are present in the Islamic schools, Muslim communities, as well as their families. And to also potentially develop some resources for Islamic schools, Muslim communities, and families to deal with these issues, to better equip them. And that's definitely part of the work that I will continue to be doing, you know. So facts about suicide. So just giving you guys some statistics. The National Center for Health Statistics, this is their most current for 2018. And suicide ranks as the 10th leading cause of death in the US. When we look at the second line here, it ranks as the second leading cause of death for 15 to 34 years old. And that is kind of where I'm going to draw the focus here, is that the second leading cause of death. So we're seeing that this is a serious issue in that age range, which is where I'm going to be doing the focus of this presentation at. You'll see the total number of suicides, more males than females, and firearms being the most commonly used. So a little bit of definitions. According to the APA, suicide is a death by self-directed injurious behavior with the intention of dying. A suicide attempt is a potentially non-fatal self-directed injurious behavior, which may or may not have serious medical consequences, but the intent was to die. Suicidal ideation is more of a spectrum, and we see that it ranges from severity. It could be a very vague wish to die, like I don't want to wake up in the morning, or what would happen if I didn't wake up in the morning, to something that is more active and specific with, for example, I'm going to go and jump off the Brooklyn Bridge. So we see that when someone is talking about suicidal ideation, that's normally when we do what's called a suicide assessment. And that is when we sort of gauge where are they on the spectrum of suicidal ideation. So some risk factors that have led to the increase of suicidality amongst adolescents, you'll see that this is a pretty long list, but I would focus more on sort of the recent or serious losses that oftentimes, sort of go unaddressed, because again, there's this stigma attached to mental health in the Muslim community and in families. And so, we don't really address it when there is this sense of serious loss, which can happen and has a lot to do with sort of the family structure a lot of the times. Mental disorders, of course, any, previous suicide attempts also always is a risk factor. Alcohol and other substances use disorders can be also a history of abuse or trauma, neglect, and victims of bullying. So these are some of the ones that significantly we see more of. So I'd like to actually introduce my peer from Muslims Thrive, Saba Chowdhury. She is a psychiatric epidemiologist at the New York State Psychiatric Institute, and she is conducting an analysis right now for the National Suicide Prevention Lifeline Project, and she has done a number of other suicide prevention related projects, and she is sort of the person I went to kind of get more clarity in terms of the research about what has been going on nationally and state and in New York State in terms of suicide prevention. So without further ado, Saba Chowdhury.
Bismaa, thank you so much for introducing me. So the first thing I want to talk about is suicide contagion. So suicide contagion is basically the process by which knowledge, either direct or indirect, of one suicide facilitates the occurrence of a subsequent suicide. And we see evidence for suicide contagion in three different sources. First is through the impact of exposure to suicidal peers, and then we see it in the impact of the media, and also in suicide clusters. And these three are interrelated. So I want to talk a bit about the impact of the media. We see a greater increase in suicide when the frequency of stories increases. So we see a dose-response effect, and also when a higher proportion of the population is exposed to the story. When headlines are dramatic and the prominence of the story increases. So imagine a headline like this: big, bold letters on the front page, "Doctor commits suicide in Manhattan." When we use language like that, it has a negative effect on the entire population. So we have to be very careful. And I also want to include that the impact of the media isn't just contained to newspapers and publications like that. We also have to be very mindful when we send out things like community newsletters and mass email chains inside the Muslim community, because it can have a similar negative effect if we don't word things the right way. So what happens when media does follow suicide reporting guidelines based on research? So we do see that repetitive reporting is associated with increases in suicide rates. However, writing about the adoption of positive coping mechanisms by suicidal individuals is associated with a decrease in suicide rates. So that's good. So here, I just want to show you a graph that illustrates very well the effectiveness of following media guidelines. So as you can see here, the suicide rate in the Vienna subway system significantly decreased after they implemented media guidelines. So this is basically intervention, prevention, and postvention in action. And I also want to say that though the impact of the media exists, it's not a monolithic effect. Interactive factors exist. You have to consider the audience, the stories, and how relatable the stories are to the audience. And this provides a segue to discuss suicide clusters. So a suicide cluster is basically when we see an excessive number of suicides occurring in close temporal or geographical proximity. So here I want to show you some statistics. At a minimum, 5 youth suicide clusters occur each year in the US, and approximately 5% of teen suicides occur in these clusters. So this is a big problem. So which communities are susceptible to suicide clusters? Well, there is no one type of suicide cluster-prone community. It can happen in any group at any time, regardless of socioeconomic or ethnic profiles, as you can see here. But they are most common among teenagers and young adults. So we really have to make sure that we protect our young people by taking the right measures for suicide prevention. How can we contain suicide contagion? One of the ways is through intervention. And I'm very familiar with the National Suicide Prevention Lifeline because I evaluate their services. So now I'd like to share with you some great news that I'm particularly excited about, because the formation of this number was based on our research group. And this number is called 988. It will be for mental health emergencies, and it will be analogous to 911. So this doesn't mean that the 10-digit National Suicide Hotline Lifeline number is going away. We'll just have one additional number, 3 digits versus 10, that people can call for mental health emergencies. And the interesting thing here is that the FCC will be voting on establishing this number formally this month. So that's pretty cool. And it should increase service utilization by people who are facing mental health emergencies. So lastly, I just want to say suicide prevention requires effort and commitment from all of us together. So we do this through health promotion, through social support, through intervention, like I just talked about, and postvention, which is basically the way that we respond as a community after someone dies in this manner. So I hope that this presentation was useful and informative. Thank you so much for the opportunity. Assalamu alaikum.
So thank you, Saba, for that information. These are just some of the definitions and points
Bismaa,
that
thank you.
Saba was mentioning. Just going to go through these. This was the Vienna subway system graph that she was mentioning. And as you can see, the numbers go up and down according to the implementation of media guidelines. This is the suicide clusters definition and the statistics on those, which again, you'll see this is pretty significant. These are the different types of suicide clusters. I can also say that, if in a community or school, if we have, suicidality amongst the adolescents, there is, one or two, it's more likely to end up being a cluster. And of course, any community is susceptible to this. Of course, the National Suicide Prevention Lifeline and 988, which the FCC is voting for this month. I think that's really exciting, and I'm really hoping that this goes through because I feel like this is going to really help, connect people to getting mental health support. So on to my case study. So this is the case that I had with a 14-year-old South Asian young female who lived with her family in Queens. She doesn't have any past history of, psychiatric history. She had never been in any kind of treatment, therapy, or medication management. Now, she had recently started going to high school, and so this was a time of transition for her. And so she was feeling, somewhat overwhelmed by all of these different transitions and changes that she was going through, not to mention like changing schools and losing her old friends. So not really having that support network that she had normally had, and obviously having a bigger workload being in the 9th grade. And also there was some bullying that was going on from some of the other girls in her class. So she became more depressed and anxious and experiencing a lot of hopelessness and low self-esteem because of all of this. She had some panic attacks while in school, in class. Some of it was related to test anxiety, but a lot of it was due to psychosocial factors, like I mentioned. Her symptoms started around the time that she started high school, and I saw her 6 months after she had started high school, and over time, these symptoms began to get worse. And, she eventually shared with her mom how she was feeling, and her mom brought her in to engage in therapy with me. So soon, there was also episodes actually of her engaging in some self-harm via cutting, and that had happened prior to her coming to me. And in the beginning, when we were working together, that was not the case. She had not been engaging in any self-harm at the time. In terms of her social history, she's born and raised in New York, and she attended an Islamic school since the age of 8. She also enjoyed playing a lot of sports, but that also declined over time because of how she was feeling. And in terms of family history, nothing was really reported, which is not surprising because, we don't really talk about or address those things in the Muslim community. So no substance use or trauma history, just some verbal abuse by her father, but not very serious or something that was significant, and no HI. So in terms of her suicide risk assessment, when I completed that, her risk was low. She had some suicidal thoughts, but they with some vague ideas to cut her wrist or overdose on pills, but nothing that she ever actually intended to do or was ever really serious whenever she was, whenever I would do this assessment with her when she would report having suicidal thoughts. She like thought of her parents and her siblings as her protective factors, and she did become a little bit impulsive and engaging in cutting behaviors. Now we want to remember that sometimes a cutting behavior is not necessarily having to do with suicide, and it is more of a way of engaging in self-harm and then feeling a sense of relief after the fact. So this was something that she did a few times while in my care, and this would happen oftentimes when she was really triggered and feeling overwhelmed. So the plan was for her to engage in once a week therapy with me and attend a support group for adolescents, which was in her school, continuing to engage in safety planning, involving the family, being able to just understand and identify her own triggers, being able to think of what are some coping strategies to help her feel better. And of course, her mom was her emergency contact and treatment partner, who was, the one I was always in touch. So, I kind of conceptualize this case in terms of her relationship to her family, the community, and the school, because she was, someone who was going to the Islamic school and, also took part in different things happening in the Muslim community. And I actually, knew, had worked with this community before, had done some workshops here in the school, in the community. So this was sort of known to me, which became an advantage in this particular case when it came to supporting this client. So the risk factors that were identified here in the family was the lack of awareness, obviously, which is, I think, one of the most important things that sort of go on, and inability to validate the child's thoughts and feelings, and how that is really challenging, and that comes from that lack of awareness and understanding about mental health issues. Now, in the school, we have the bullying, and there's also a lack of resources in the school regarding mental health. There wasn't any, social worker or therapist or anybody that was working in terms of helping support the mental health of the students. And the staff was also not trained to identify any mental health issues with the students. In terms of the community, there was always that stigma related to mental health and no resources to speak of, which is unfortunately the case with a lot of Muslim communities. So these are the interventions that I used when working with this case. And so with the family, we did family therapy. With the psychoeducation, I provided that to everyone, to the family and to the client, having to do with what is depression, what are risk factors, how do we prevent suicide, engaging the family with the safety planning piece, and also recommending individual therapy for parents, because oftentimes it was hard for them to deal with this adolescent who was going through so much, but they were not sure how they could support her. The school, so what we did there was I helped them hire a part-time school counselor who did individual and group therapy with the students, completed assessments, and also engaged in crisis intervention when she was on site. She did some workshops with the 7th to 8th grade parents. I also did one of these workshops myself, and this was sort of where we found most of the suicidality, and there were a few students who were actually going through depression and anxiety, and this was 7th to 8th grade, and so this is why our focus was with that those particular grades. And then there was like some psychoeducation that happened for the teachers. And so one was the Muslim mental health first aid for youth, which was done through Muslims Thrive. And they also completed a PESI training, which was geared towards self-harm, suicide, and depression. With the community, there were some workshops and lectures, one that I personally did, one completed by a school psychologist, and one done with Khalil Center. Also, some resources were shared with the community, which was a list of mental health resources through the Muslims Thrive website. And of course, the next steps that are identified here is to conduct a needs assessment to develop more programs to target the most important mental health issues that we're finding in the Muslim community. These are some resources for suicidality, as you can see, as well as for youth, as well as adults. And really that is the end of my presentation with all of you. And I really hope that this has been a helpful to all of you in terms of how to deal with suicidality amongst Muslim adolescents, teenagers, and sort of how to use the family, the community, and if the child goes to a Muslim school, how can we use all these three factors to help support the child in getting better and decreasing the suicidality and increasing the hope to live, to move forward, to work on their goals. It's definitely not going to be easy to turn things around. And of course, given everything else that's happening right now in the world, we're seeing that there's an increase in mental health services needed overall. So this might be looking a little bit more different by next year, but this is, I think, definitely a place and a space for us to continue to work on in order to help Muslim youth. So thank you so much, everyone, for your time. I really appreciate it. Goodbye.